Hi, my name is Dr. Richard Savel, and I am the director of the Surgical Intensive Care Unit at Maimonides Medical Center here in Brooklyn, New York, and I'm a professor of clinical medicine and neurology at the Albert Einstein College of Medicine in New York City. This is a presentation that I have been organizing since I finished my fellowship in 2002, focusing in on some of the most important clinical trials published in critical care medicine over the last decade or so. So I'd like to go over some of these important trials with you today, and I hope you find them to be useful. I have no disclosures. So the major areas that I'd like to focus on include ARDS and what used to be known as acute lung injury. I'd like to talk about some of the important data behind glucose control in the intensive care unit, where we've been, where we're going. Also to talk about the role of corticosteroids for patients with severe sepsis syndrome and septic shock. And then an update from the last year or so on some important, interesting articles. Again, if you go to websites like sccm.org and click on guidelines, or go to survivingsepsis.org, and again, one of the major areas of importance is the Surviving Sepsis Campaign guidelines that have been revised in the years that you see here, with the most recent publication in 2012. I'd like to begin by discussing the acute respiratory distress syndrome and some of the basics. Again, this entire talk is primarily aimed at a house officer in their ICU rotation. So first is the definition of ARDS, and there have been some recent modifications based on what's called the Berlin criteria, but still the basic definition is fairly unchanged. So first of all is the correct clinical scenario, usually direct or indirect lung injury, bilateral, usually asymmetric infiltrates on the chest x-ray, and then measuring the degree of hypoxemia by utilization of what's known as the PaO2-FiO2 ratio, 300 to 200, 200 to 100, and less than 100 being mild, moderate, and severe, respectively. And then no evidence of left atrial hypertension, and this does not mandate the use of a pulmonary artery catheter. And the mortality of this has dramatically changed over the last few years, and again, when this particular slide was made in the early 2000s, there was a mortality up to 50%, but that's dramatically lower now with some of the focused areas for high quality care for patients with the acute respiratory distress syndrome. Again, I like this slide because it helps people organize their thoughts about ARDS in terms of causes being either direct lung injury or indirect lung injury. Some common causes of direct lung injury, including pneumonia and aspiration. Some common causes of indirect lung injury, including severe sepsis, trauma, shock. Uncommon causes of direct lung injury you can see here, and important ones for indirect lung injury, including acute pancreatitis and transfusion-related acute lung injury. Again, this is a slide from a while back, but I really like it very much, comparing and contrasting the happy normal alveolus with its nice type 1 cell here and the type 2 cell, and you can see the nice thin interstitium. You can almost visualize the carbon dioxide and oxygen easily going back and forth here. And this is in contradistinction to the enraged, inflamed alveolus over here with acute lung injury, with protein-rich fluid in the alveolus. You can see the thickened hyaline membrane. You can see why we have so much difficulty oxygenating patients who have this disease. You can see the diapedesis of the neutrophils into the widened edematous interstitium. So one of the main therapies for ARDS is low tidal volume ventilation, but let's focus in on some of the theory and data behind that. So the concept is this term VILI, ventilator-induced lung injury, and that patients who have respiratory failure require often intubation and mechanical ventilation, but the issue is, does the very fact that the patients are intubated require or perhaps worsen their underlying lung injury? And I'd like to go over some of the ideas there. So this is the volume pressure curve showing that the idea behind a lung protective strategy is to give enough positive end expiratory pressure to prevent repetitive opening and closing of the alveoli, but low tidal volumes to prevent repetitive overdistension as well. And although there are some smaller trials, the main trial that one still quotes was published in 2000 in the New England Journal of Medicine, ventilation with lower tidal volumes as compared with traditional tidal volumes for acute lung injury and the acute respiratory distress syndrome. And what they did was randomize 861 patients with ARDS to either what was then called low tidal volume of 6 mLs per kilo predicted body weight with a plateau pressure less than 30, and high tidal volume of 12 mLs per kilo with a plateau pressure less than 50. And the bottom line was that the percentage of patients who had death before discharge home was less in the low tidal volume group, approximately 40% versus 31%, with a number needed to treat of 11. And the percentage of patients breathing without assistance by day 28 was significantly higher in the low tidal volume group. You can see 66% versus 55%. So the key take-home message here, and it's a summary of a tremendous amount of data, is that low tidal volume ventilation, which is currently considered a standard of care for patients like this of approximately 6 mLs per kilo predicted body weight, is associated with improved outcomes. Some of the controversies in this area include the fact that there was no normal tidal volume chosen, but the consensus in the critical care community is still that this approach is a reasonable one. Others say that it wasn't that the tidal volumes were low, but that your plateau pressures during an inspiratory pause were kept lower. And again, it is felt that a combination of approaches with low tidal volumes and low plateau pressures is really what matters. And the debate continues. I would say the debate doesn't really continue, and that it is an international consensus that low tidal volume ventilation using a protocol such as the ARDS-NET protocol is certainly a reasonable approach for managing patients with it. I think some of the things that have changed since then is the fact that something like ECMO, extracorporeal membrane oxygenation, is becoming more common for patients like this. And there are some other accepted modes, such as APRV, with less data behind them. Some of the other controversies in this area is whether high versus low PEEP should be used. This is the alveoli trial, published in the New England Journal of Medicine in 2004, with no obvious change in outcome. And so, as was published in the Surviving Sepsis Campaign guidelines, there are two different protocols for combinations of FiO2 and PEEP, using higher PEEP or lower PEEP. One of the other controversies is the role of corticosteroids for ARDS per se, and the consensus in the literature is that there's no obvious benefit, although there are some complex results. And you can read more about this in the reference you see here if you're interested. Another exciting article that was published in 2006 were two articles in the New England Journal of Medicine known as the FACT trial, Parts 1 and 2 Fluid and Catheter Treatment Trial, comparison of two fluid management strategies in acute lung injury, and again you can see the reference here. And the concept is that if your patient was not in shock and had good perfusion with a good urine output, a target of a lower central venous pressure was associated with decreased time in the ICU, decreased time on the ventilator, with no change in mortality. And the second part of it was that it was not mandated that a pulmonary artery catheter was required. It was not required. There was no obvious benefit to the use of a pulmonary artery catheter when you were providing a form of diuresis for patients with acute lung injury. And again, the big question that the FACT trial answered was, can one diurese non-cardiogenic pulmonary edema safely? And the answer appears to be yes. So in summary, low tidal volume ventilation appears to be good. High PEEP does not appear to hurt. And I would say there's more and more data that the use of low tidal volume ventilation as a prevention is reasonable and is part of some patient safety initiatives, such as the Johns Hopkins Armstrong Institute CUSP for MVP project. An interesting area is the use of neuromuscular blockade for patients who are critically ill. Again, for many years, the focus was to try and avoid them at all possible, when at all possible, because there's concerns that you can develop critical illness polyneuromyopathy from it. And there was an exciting, interesting article published in 2010 in the New England Journal of Medicine called the Accuracies Trial, Neuromuscular Blockers in Early Acute Respiratory Distress Syndrome. You can see the reference here. And they did a multi-center double-blind trial looking at 340 critically ill patients with severe ARDS, and you can see here their PF ratio definition. And they were to receive either 48 hours of cisatracurium or placebo. And you can see here the structure of the trial. The primary outcome was the proportion of patients who died before hospital discharge or within 90 days after study enrollment, adjusting for baseline comorbidities. And interestingly, the hazard ratio of death was 0.68, statistically significant, and the crude 90-day mortality was statistically lower in the group. You can see here approximately 32% versus 41%. The p-value was not quite statistically significant, but if they looked in the group of patients with a PF ratio less than 120, and it was 2/3 of their patients, then they found statistically significant difference, again 31% versus 45% in 90-day mortality. So this is interesting. Again, they had a significant difference in pneumothorax rate. It seems like their pneumothorax rate in the placebo group was quite high, and they couldn't determine any obvious increase in ICU-acquired weakness in the group that received the 48 hours of neuromuscular blockade. There were some controversies, although again, it isn't mandatory that a train of 4 be used. They only studied one particular drug. It was not blinded, and this high rate of barotrauma is somewhat concerning. I put up here a slide showing some of the basic theory behind why, this is by Dr. Slutsky, why possible mechanism by which neuromuscular blocking agents might lead to improved survival in patients with the acute respiratory distress syndrome. And I'll let you pause and look this over in more detail if you want to see some of those details. So it has become, since this article was published, part of a reasonable standard approach that if you have early on a patient with severe ARDS, many intensivists would consider early on 2 days use of cisatracurium based on the results of this interesting trial. Again, this is of historical interest, but for quite a few years, between 2002 and the present time, there was a focus on the role of activated protein C as an adjunctive therapy for patients with severe sepsis syndrome. And to make a long story short, this drug was taken off the market in 2011 because it was causing bleeding and they were unable to replicate the initial benefit shown in the initial studies. I'd like to take a few moments to talk about another fascinating area in the field of critical care medicine, which is glucose control in the critically ill patients. So hyperglycemia is common in the ICU, and for many years, there was not a particular focus on managing glucose while the patient was in the intensive care unit, until this study was published in the New England Journal of Medicine in 2001 by Dr. Vandenberg, Intensive Insulin Therapy in Critically Ill Patients. And their group looked at approximately 1,500 patients and randomized them to intensive insulin therapy, what we call tight glucose control, to begin an insulin infusion if the blood glucose was greater than 110 milligrams per deciliter, and conventional therapy with an insulin infusion if blood glucose was greater than 215 milligrams per deciliter. And by doing this, they were able to reduce ICU mortality overall by approximately 32%. You can see the numbers here. And if they were in the ICU for more than 5 days, they were able to reduce the mortality by approximately 50%. There were some concerns about potential for hypoglycemia, that these were mostly patients after cardiac surgery. But regardless, this really took on, with great passion, throughout the world that tight glucose control became a de facto standard of care for high-quality ICU management. But then there were some follow-up studies published in 2006 looking at medical patients. And if you look here at the results of the Vandenberg study in 2006, the intensive insulin therapy reduced blood glucose levels but did not significantly reduce in-hospital mortality. And among the 433 patients who stayed in the ICU for less than 3 days, mortality was actually greater among those receiving intensive insulin therapy. And although the risk of subsequent death and disease was reduced in patients treated for 3 or more days, these patients could not be identified before therapy. This was concerning. I'd like to now go over some subsequent articles that have really swung the pendulum back in terms of the role of glucose control in the intensive care unit. The first was the VICEP study. This was published in 2008 in the New England Journal of Medicine, Intensive Insulin Therapy and Pentastarch Resuscitation in Severe Sepsis. So again, the concept is doing critical care research is so difficult that they were trying to combine 2 big critical care questions in one study. It was a 2x2 factorial design to evaluate the safety and efficacy of intensive insulin therapy compared with conventional insulin therapy, and to evaluate the safety and efficacy of hydroxyethyl starch compared with Ringer's lactate in patients with severe sepsis syndrome or septic shock. They randomized patients with severe sepsis to either intensive insulin therapy or conventional insulin therapy, and either to a 10% pentastarch, low molecular weight hydroxyethyl starch, or modified Ringer's lactate for fluid resuscitation. The trial was stopped for safety reasons, and you can see here that the intensive insulin therapy group was able to get a lower serum glucose, but there was no difference in the rate of death or organ failure score, but the rate of severe hypoglycemia was much, much higher in the tight glucose control group, and the rate of serious adverse reactions were also higher in the intensive insulin therapy group, as you can see here. Importantly, hydroxyethyl starch therapy was also associated with higher rates of acute kidney injury, as you can see here, 35% versus 23%, and the need for renal replacement therapy. So there was a direct correlation between the cumulative dose of hydroxyethyl starch and both the need for renal replacement therapy and the rate of death at 20 days. And the Cox regression analysis identified the occurrence of hypoglycemia as an independent risk factor for death from any cause, and this has really become the theme for tight glucose control over the recent time in ICU, which is to avoid hypoglycemia. Some of the important results here, as you can see, taken together, our study and the medical ICU study by Dr. Vandenberg et al. Established that intensive insulin therapy has no measurable, consistent benefit in critically ill patients in a medical ICU, regardless of whether the patients have severe sepsis, and that such therapy increases the risk of hypoglycemic episodes. And in addition, they found important issues with hydroxyethyl starch, and since then, it is not considered an appropriate standard of care to use hydroxyethyl starch solutions in the intensive care unit. So an important follow-up study was the NICE sugar trial. This was published in 2009 in the New England Journal of Medicine, Intensive versus Conventional Glucose Control in Critically Ill Patients. And it stands for Normoglycemia in Intensive Care Evaluation, Survival Using Glucose Algorithm Regulation. Boy, that's a mouthful. So 6,000 patients randomized to either tight glucose control, as you can see here, versus conventional glucose control. And this is important. So 90-day mortality was higher, statistically significantly higher in the tight glucose control group, 27.5% versus 24.9%. The hypoglycemia rate, as you can see here, approximately 7% versus 0.5%. This is a very, very big deal. This is a cause for pause. Again, this is showing the probability of survival, showing that in the tight glucose control group, they were statistically going away from each other, that you were going to be worse off if you receive tight glucose control. And again, It's 2015 as we record this. It's to be cognizant of glucose control in the ICU, but don't try to make it for tight glucose control. In general, we target 150s, 180s now in the intensive care unit as a target glucose. One of the other continuing controversies is the role of corticosteroids for severe sepsis syndrome, and I thought I would help share with you some of the important literature behind this topic. So in the past, there was a thought that giving high doses of short duration steroids would be helpful. There was a 1995 meta-analysis with no overall beneficial effect of corticosteroids in patients with septic shock, and you can see the references here. In the late 1990s, early 2000s, there was a thought that patients should be looking at receiving hydrocortisone 100 milligrams 3 times daily for 5 to 7 days as a form of stress dose steroids. This was associated with a shorter duration of vasopressor dependence and questionable improvement in mortality. And this slide really remains the huge controversy. Is this correct or not? So there was an important study published in 2002 by Anand et al. In JAMA called The Effective Treatment with Low Doses of Hydrocortisone and Flurdocortisone on Mortality in Patients with Septic Shock. So this group, they randomized 300 patients with septic shock to either hydrocortisone 50 milligrams IVQ every 6 hours plus flurdocortisone 50 micrograms via the nasogastric tube daily for 7 days, or placebo. All other care was the same. And then they did something interesting and controversial because, again, it's very difficult to determine even how to determine if a patient has adrenal insufficiency, if they're critically ill. They were given a 250 microgram cortisone stimulation test, and the results divided patients into what were called non-responders, where the serum cortisol was increased by less than or equal to 9, and those were called patients with partial adrenal insufficiency, or responders, where their serum cortisol went up by greater than 9, and those were patients who were felt to have no evidence of adrenal insufficiency. So again, a non-responder had partial adrenal insufficiency according to these definitions, and a responder had no evidence of adrenal insufficiency. So some of the important results from the Anand trial revealed that 76% of all their patients met their criteria for partial adrenal insufficiency, and that in that group, statistically, the 28-day mortality decreased from 63% down to 53%. And as you've seen in some of my other videos, the mortality from septic shock is much lower in 2015. In the patients who responded, they could not find any difference in outcome. So the conclusion from this trial was that 7 days of low-dose steroids was associated with an improved outcome in sepsis if partial adrenal insufficiency was present. But there were some follow-up trials that called into question the validity of this particular trial. So this was published in 2008, again in the New England Journal of Medicine. The Corticus trial, hydrocortisone therapy for patients with septic shock. Dr. Sprung is the lead author, and you can see Dr. Anand, still one of the authors. They're still trying to answer the question, is there a value to corticosteroids as part of therapy for severe sepsis syndrome? So again, they looked at patients with septic shock, and they gave hydrocortisone 50 milligram intravenous bolus every 6 hours for 5 days with a taper, and then it was stopped. And you can see here the structure of the study. The primary endpoint at 28 days was the rate of death at 28 days in patients who did not have a response to corticotropin. Secondary endpoints were the rate of death in all patients, the rate of death in the ICU, others you can see here. So on this slide, you can see the rate of death in patients who did not have a response to corticotropin, and you can see there was no difference, 36.1% mortality versus 39.2% mortality. And in those patients who did have a response to corticotropin, again, no response. And in all patients, again, no statistically significant difference in the 28-day mortality in patients with septic shock, whether they received steroids or not. And as you can see here, there were no other secondary outcomes were improved, including the rates of death in the ICU, or there was an improved reversal of organ system failure. But this seems to be a common theme in studies of patients with septic shock and the role of steroids, that you seem to be able to demonstrate a slightly earlier improvement in organ failure, but you can't correlate that with any kind of improvement in overall mortality. There was an increased incidence of superinfections in the hydrocortisone group, and there was an increased incidence of hyperglycemia and hypernatremia. So in summary, in the Corticus trial, the use of hydrocortisone did not decrease mortality in a general population of patients with septic shock, and the lack of improvement might be related to the increased incidence of superinfection and new episodes of sepsis. And they could not really demonstrate that using a cosentropin stimulation test really could help find a group of patients versus not who would respond to steroids. So on the basis of these findings, hydrocortisone cannot be recommended as general adjuvant therapy for septic shock, nor can corticotropin testing be recommended to determine which patients should receive hydrocortisone therapy. Hydrocortisone may have a role among patients who are treated early after the onset of septic shock who remain hypotensive despite the administration of high-dose vasopressors. And this is really the subgroup of patients where consideration should be given to the utilization of corticosteroids. And again, I'm just quoting here directly from the most recent Surviving Sepsis Campaign guidelines, as you can see here, just reiterating what I described previously. Again, focusing in on the fact that considering it in the subgroup of patients who are early on unresponsive to vasopressors, and that using a cosentropin stim test does not really help. I'd like to focus in on a few more areas of interest for me, such as prone position in ARDS. There's some recent interesting important data about that. I'd like to talk about this issue of the timing of tracheostomy for patients who are critically ill, and two other recent studies, one looking at albumin for sepsis and the other looking at does the particular blood pressure target matter in sepsis. So there are numerous adjunctive salvage therapies for patients with ARDS, such as the use of neuromuscular blockade, and this is another one, prone positioning in ARDS. This is not a routine standard of care in the United States yet. It's quite institution dependent, and this was important recent data published in 2013 in the New England Journal of Medicine. So the concept here is that oxygenation is improved when patients are in the prone position, and it was unclear if this improvement in oxygenation would be associated with an improvement in mortality, given the fact that, for example, in the ARDS trial, the group that received lower tidal volumes had worsening oxygenation, but actually had improved outcomes. So some of the proposed mechanisms for this improvement in prone positioning include increased chest wall elastance, recruitment of alveoli, and reduced ventilator-induced lung injury, as well as improvement in VQ mismatch. So the Prosatrial prone severe ARDS patient study was a multi-center prospective randomized controlled trial of 466 patients with severe ARDS who underwent prone positioning sessions of at least 16 hours, and they defined this as a PF ratio of less than 150. They had a stabilization period of 12 to 24 hours, and patients who were prone were turned within the first hour after randomization, and they remained in prone position for at least 16 consecutive hours, and this was used every day up to day 28. You can see here the average numbers of sessions per patient and the duration. So the primary outcome was 28-day mortality, and you can see here the numbers in each group around 230. And this was rather stunning. So by proning these patients, they were able to reduce mortality at 28 days from 32.8% down to 16%. Obviously, this is statistically significant. This was rather surprising to the members of the critical care community. This was as much of an improvement in outcome as using antibiotics for pneumonia. So the 90-day mortality was also improved. This was performed primarily in France in a group of hospitals where proning was already a standard of care. And so actually unproning these patients was the concerning part. Here's the Kaplan-Meier curve just demonstrating what I described previously. And so here's the generalized consensus in the United States regarding this study, is that there's a concern for a lack of biological plausibility for that much of an improvement. As I mentioned, this was done in 26 ICUs in France and one in Spain who've been using prone positioning for many years, and it's unclear how relevant this would be to the United States. Concern for complications such as endotracheal tubes becoming dislodged or central lines. And there's some other data here if you're interested, and there's a link to a video from the New England Journal of Medicine website to see how they actually perform the proning procedure. They do not use any particular special equipment. This is a particular area of interest for me, the timing of tracheostomy, because it's been fascinating to me how much of a disconnect there has been between my clinical experience personally as an intensivist now for over a decade and what the literature has shown. And the idea is that from a clinical standpoint, if a patient clearly needs a tracheostomy early on, doing it makes the patient much easier to manage, much easier to care for, and both from a clinician perspective and from a family perspective and a patient perspective, everything seems to be more positive. But what the literature continues to show is that you don't actually change mortality by doing this. And so I'd like to share with you the most recent data behind this. This was published in JAMA in 2013, early versus late tracheostomy on survival in patients receiving mechanical ventilation. This is the Trackman Trial. And again, the timing of tracheostomy in the ICU has been somewhat controversial for years. And as I mentioned previously, it clearly appears to be associated with improved comfort, decreased time on the ventilator, decreased time in the ICU, and potentially decreased incidence of pneumonia. Whether or not you're changing mortality by performing a tracheostomy is much less clear. This has been a very difficult area to study because it doesn't easily lend itself to a randomized trial. It doesn't lend itself easily to determine if a patient would meet criteria for early or late, and how you even define early and late remain controversial. So the Trackman trial was an open, multi-centered, randomized clinical trial of 72 adult ICUs. You can see some of the data here. These were 900 adult patients on mechanical ventilation for less than 4 days, and they were identified by their doctor to likely require at least 7 more days of mechanical ventilation. And for those of you who practice critical care medicine, you understand that that's very difficult. So they were randomized to early within 4 days or late after 10 days, if a tracheostomy was still indicated. The primary outcome was 30-day mortality. I believe that's controversial. So 455 patients were assigned to early tracheostomy, and 92% of those patients actually received a tracheostomy. 454 patients were assigned to a late tracheostomy, and this is the key, is that many of these patients never actually underwent a tracheostomy. There was no change in 30-day mortality and no median change in ICU length of stay. This is a slide looking at the distribution of the tracheostomy timings in the early versus late group. And the crucial issue here is, as you can see, in the late group, a large percentage never required a tracheostomy. This is the Kaplan-Meier curve of survival. So the Trackman trial, from my perspective, it's unclear how relevant it is to my personal practice because the mean age is quite low, or low compared with where I work. And from an intensivist perspective, the tracheostomy remains a tool to help patients with critical illness to be managed on the ventilator, and that waiting 10 days seems to be reasonable. And it's fairly clear that we are not changing mortality by performing a tracheostomy, at least from this study. And then the last two trials I'd like to talk about, one is on albumin. This was published in 2014 in the New England Journal of Medicine, the Albumin Italian Outcome Sepsis Trial. Albio study, 1,800 patients. Again, we're focusing in on resuscitation of crystalloid versus resuscitation of crystalloid plus albumin. Again, the SAFE trial published in 2004 in the New England Journal of Medicine demonstrated the safety of utilizing albumin. And in this trial, early goal-directed therapy was used for the early phase. It's very unclear to me why they targeted a particular albumin level. That's not normally how this is done for patients with sepsis. They looked at a 28-day mortality, and you can see here some of the secondary outcomes. The patients in the albumin group had a higher mean arterial pressure and received a less amount of fluid, but the total amount of fluid given did not differ. Neither did the 28-day mortality or 90-day mortality. This is just some of the data showing serum albumin and net fluid balance. This is the serum albumin difference between the two groups and the net fluid balance. So the conclusions here are that albumin appears to be safe to be given as part of a resuscitory strategy in patients with severe sepsis and septic shock, but it, at least in this particular study, was not associated with any particular survival benefit. And lastly, there was a recent study looking at different target mean arterial pressures. So this was the sepsis PAM investigators. The PAM in sepsis PAM stands for pression artérielle moyenne, mean arterial pressure. This was from France. High versus low blood pressure target in patients with septic shock, published in the New England Journal of Medicine in 2014. 776 patients with septic shock. You can see here they randomized them to a mean arterial pressure target of between 80 and 85 versus a more normal 65 to 70. In general now, anywhere between 60, 65 millimeters of mercury is considered a reasonable target. The primary endpoint was 28-day mortality. And again, there was no difference in mortality between these two groups and no change in 90-day mortality. The higher MAP group had a higher incidence of atrial fibrillation, and confusingly, the lower MAP group had a higher incidence in the need for renal replacement therapy if you had chronic high blood pressure. And so one of the theoretical issues is if your patient walks around with a higher blood pressure, do you need to give them a higher blood pressure while they're septic? And the answer from this particular study and others is maybe. So this study showed no change in 28 or 90-day mortality in patients with septic shock by increasing their MAP target, and they found a twofold increase in the incidence of atrial fibrillation. So my conclusions from this study are that evidence-based critical care is exciting, it's challenging, it's very dynamic, sometimes confusing. But one thing remains unchanged, that consensus and collaboration between, in my world, as a surgical intensivist, the surgical team, and the multidisciplinary critical care team leads to the best possible outcome for the critically ill or injured patient. Thank you so much for taking the time to watch this presentation.